abdomen, one in head and neck, and one head and neck, and one in the thorax. Sometimes lower limbs according to the situation. And usually they give you a picture. Sometimes you have a skeleton. This is picture is from the Royal College of Surgeon Museum. And this is museum. They have the picture without color. It's like something like this and have a number. So they ask you, can you enumerate? So just give me the number, like what is one, what is A, what is B, what is C? And sometimes you have a question, sometimes you don't have a question. So this is easy. This is all or none. Either you know what is this structure or you don't know this structure. If you don't know the structure, the examiner tell you this is something and ask you another question depend on that. I start in simple way in the abdomen. After that, I show you what happened in exam. Of course, you know the abdomen is 9 area, like right and left hypochondrium, right iliac, left iliac, right lumbar, left lumbar, and epigastric, umbilical, and hypogastric. It's just mid-clavicular, and this is L1, this is L3. The important to know, if you make a hernia, you put incision here. This incision is above the inguinal ligament, about 1 cm above the inguinal ligament. So it is in T12, not L1. Although the ilioinguinal nerve L1 and 2 supply the area of the inguinal canal, but the incision is made in the skin dermatome of the level of T12 because this is the dermatome in the site of incision. Of course, the umbilicus is 10 T10. Sometimes they ask you about the point between the anterior superior iliac spine and symphysis pubis, which is the mid-inguinal point, which is for femoral artery, and the midpoint between anterior superior iliac spine and the pubic tubercle, which is the deep inguinal ring. Of course, this is inner of the thigh is innervated by genital branch of genitofemoral and ilioinguinals, they overlap over each other. So in the anesthesia for a hernia, usually we give nerve block for both genital branch of genitofemoral and ilioinguinal nerve.
دكتور في مشكلة في الصوت غالبا.
لا مش كده سامعني كده؟
لا في وش كده.
Okay, I will try to be clear.
مفيش صوت وش أو حاجة مش عارف.
Okay.
حضرتك.
Maybe. Okay. After that, okay. After that, we have the muscle of the posterior abdominal wall, which is psoas major, and psoas major is inserted in the. Anyone can ask where is the insertion of iliopsoas? We can take one. Yes.
Lesser
trochanter. And the next question usually, what is the nerve supply of iliacus and psoas? Because it's different. Nerve supply of iliacus is. Anyone? Iliacus is supplied by femoral and iliopsoas supplied by lumbar 1 and 2. Okay. So after that, we have this station. So the exam, you have these pictures. This picture either fresh or plastinated, but not colored. And they ask you, what is this landmark? So you can find, for example, we can, like A is the spermatic cord, B is the external oblique aponeurosis and refracted, C is superficial inguinal, superficial, what is C? AB, I don't found C here, I think. C, yeah, this is, C is here. C, it is superficial epigastric, artery and vein. D is the deep ring, and E is superficial ring. So this is the way you ask it in exam. This picture is not good simply because we used for the color picture, but this is what is the museum look like. Okay, this is colored. We don't see in exam. So this is like femoral canal and femoral area, or no, this is inguinal canal, and this superficial ring, and this is a deep ring, and the big artery, and these branches, which is inferior epigastric arteries and. Okay. Of course, this is the stomach. Again, it is colored. So we have a stomach, we have pancreas behind, we have big arteries, and we have vein, and they have connection of portal vein. At least you know how to enumerate. This is the branches of celiac axis, which is splenic, hepatic become gastroduodenum after that, and left gastric. Of course, this colors is not common exam. I just demonstrated, I show what in common exam after that. The bed of the stomach is very important to be asked about. Structure behind the stomach is a pancreas. They have splenic artery, which is corrugated. And this is explained in some perforated peptic ulcer. They can erode the splenic artery and cause severe bleeding. This is the same of the duodenum, like first part, second part, third part, and the relation of the duodenum. Also, it is important to know. This slide is very important, is the theory, because the common disease in England is the abdominal aortic aneurysm. And they ask you, if you have big abdominal aortic aneurysm, which vein can be kinked? Anyone have an idea? Which vein is affected, or which structure is affected in severe abdominal aortic aneurysm? Anyone? From, say again?
يا دكتور
Which vein is affected in huge abdominal aortic aneurysm?
left renal vein.
Left renal vein. You can see here the
Left
renal, the left renal vein is here, so it is can bigger. Nutcracker is not for the left renal vein, it is for superior mesenteric.
Okay.
Okay, so this is important because it is usually abdominal aortic aneurysm is below the bifurcation or below the renal, usually. So it's become lower. So it is important to remember this slide. This is what happened in exam. So this is the exam now. So can we have any volunteer and just enumerate thing? Dr. Abdurrahman, you are ready for that, or you need to ask anything? Or Dr. Usama, anyone? Who's ready?
يا باشا معاك يا بيه.
Which one, Abdurrahman or whom?
أنا عبد الرحمن يا
Oh,
باشا.
okay, so Dr. Abdurrahman, so you see this picture. It is the kidney from back. So can you enumerate? We give it to you
Yes.
in exam and just leave you. So can enumerate. أنا مش don't interrupt. What is A?
دكتور شيرين.
Yes. Just tell me what is A, what is B. Yes, you hear me.
أنا مريت بالسهم ولا إيه؟ يعني ليفت رينال.
لا انت مش شايف ارقام ولا ايه؟ نو انت مش شايف اي بي سي.
يا باشا لسه جاي حالا. لسه جاي لي حالا دلوقتي.
In exam we give you this. Usually it is put in the wall. And just look to this table and just tell me what is A, B, or what is A, what is B, what is C, and I leave you. Okay.
Okay.
You can start.
دي right. A right renal.
You mean right kidney?
ده on the back يا بيه صح؟
Yes, from the back. So it is.
This is left kidney.
Left kidney. B.
And B left renal vein.
Okay.
And C. left renal artery.
Yes.
And D aorta, descending aorta.
Okay.
And E IVC.
Yes.
And F ureter.
Okay.
Ureter.
So this is what happened in exam. G
is upper bowl of left kidney.
Okay, so in exam they give you the picture like this. Again, it is not colored, not blue and red, not like in other museum. This is the real museum, and this is what you found in Macbeth Atlas of Human Anatomy or Get Through Anatomy. So this is the answer. So again, so of course it is the left kidney, and the B is the left renal, and C is the left renal artery, and D is aorta, and E is IVC, inferior vena cava, and F is the left ureter. Okay, So it is easy way, easy to enumerate. Sometimes ask you some question related, sometimes give you another picture. Okay, so if you see this, we can ask you before that, if you see the ureter, the same Dr. Abdulrahman, so what is the site of constriction or restriction of the ureter normally?
السايت يبقى ميدل الميدل 1/3.
No, the sites means that the normal structure is 3. So we have this in the pelvic junction. You have when the go to through the ischial spine and when we go to through the urinary bladder. And usually pass in the tip of the lumbar vertebrae and go to down. Anatomical position in the transverse process vertebrae, the spine, ischial spine, and go to through urinary bladder. Okay, of course, this IVB is not done nowadays. This is, if you ask you, what is the relation of the ribs to the kidney? What is the surface anatomy of 2 kidneys? Which rib is related?
أنا 12 و11.
Right side is lower. Which one is lower?
Lower is left side.
Are you sure? If you go to the picture here, which one is lower? Because of the liver.
This is the right side.
Right side. Right side. This is the right side is lower. This is from the back. Right side is lower. In the past, we have subphrenic abscess. How to manage? Surgical or how to manage nowadays? Subphrenic abscess. Perinephric abscess. Perinephric. Make it perinephric abscess. So how to drainage?
percutaneous drainage, Doctor.
From the back.
Yes, percutaneous drainage guided by ultrasound. In the past, many years ago, they go to from the back and have a surgery and extract the last vertebrae, last ribs. But nowadays, percutaneous drainage can be done. In do this surgery in the past, what is the organ can be injured? Easy, tiny organ can be injured during drainage of the perinephric abscess. Something related to the thorax. If the
Specific trunk.
no. Think simple. The pleura. So in the past, if we do drainage or open drainage of the perinephric abscess, it can easy to be injured the pleura because the pleura in the back can be reached to till the level of the 12 ribs. So nowadays we don't have this problem simply because we have percutaneous drainage guided by ultrasound. This is applied anatomy. Okay, and this is again close to know the inferior vena cava, to know this left renal is pass, and in aortic aneurysm can be crushed or can be kinked because the vein is easy to be closed by severe or massive abdominal aortic aneurysm. It's common in England, of course, not common in other country. This is the same also to show you the picture. Okay, this is the ureter relation of the ureter. During surgery, especially in pelvic surgery, how you can identify the ureter? Anyone? Dr. Abdulrahman, again, we fixed one of the candidates. So Dr. Abdulrahman, how can you identify the ureter during surgery, like colonic surgery or hysterectomy?
أنا بعرفه. I know him. I know it by peristalsis.
May be difficult to know peristalsis. You need to be expert, but the relation to big structure like what you can see in this picture.
Relation with common iliac.
Common iliac arteries, yes. So it is in front or behind it?
In front.
In front. So at the level of the common iliac artery become internal iliac and common iliac. I agree with you, but suppose I am junior gynae or junior gynae and obstetric doctor working in England just first month, and they ask me to do hysterectomy. I am afraid to injure the ureter. So what is your advice to me? I am junior, first time, I don't need to go to the court. So is any something can be easy to identify the ureter? 100%. Anyone work in gynae and OBS knows the answer. Anyone work in urology knows the answer. If you are junior, first time, you're afraid to injure the ureter, post ureter.
Crossing the iliac vessels?
No, crossing the iliac vessel is anatomy. And she is... No. Some they ask other specialty to do some maneuver.
Urologist.
No.
Middle side?
No. Actually, they send it to the urology, and the urology put a stent.
Call the urologist.
Yes, no. He put a stent. Before the operation.
The G.
Okay, they put double G stent before operation and send the patient to you so you can palpate the ureter. In some gynae and OBS center, if the doctor are junior, for safety to avoid injury of the ureter, so they put double G stent before the surgery. So double G, you can palpate it, so you feel it. You understand. Okay, in England, they do that just for medical legal to avoid injury of the ureter, especially if the doctor are junior. They ask the urologist to insert double J. After operation, they remove it. Although it is another maneuver, but it is just for safety, especially for the new doctors or new consultants. Okay, so back again. So identification of the ureter or anatomy is common.
دكتور شيخ حضرتك عامل ميوت.
Okay. So you can see now. So you can see that testicular veins is become medial and in front and then laterally. Okay, just the relation of gonadal vessels. Why this is important now? Because nowadays varicose veins, varicocele can be done by laparoscope. If done by laparoscope, so you pick it inside the abdomen in this area, in the area here. Of course, it is away from the ureter, so because this become upper. So now it is the site you make collapse ligation of varicose veins. Is common nowadays. Okay, so Dr. Abdurrahman, just start again, ABC.
A, aorta, descending
Aorta. Okay.
B, right common iliac artery.
Common iliac.
C,
yes.
left common iliac artery. And
Okay.
D, left renal artery.
D, left renal, yes.
Right, E, right renal.
Okay.
And G, this is common hepatic.
Hepatic, yes.
And H, it is SMA, superior mesenteric artery.
S,
L, inferior mesenteric artery.
Okay. What about no, F? What is F? What is F?
F, it is splenic artery.
Splenic, because it is corrugated, like irregular.
Yes.
Okay, we have two arteries irregular in the body. Two irregular arteries. One in the head and the neck. One is splenic. What is in the head and the neck?
Splenic and the
facial
common facial.
Okay. All right. What is I?
I, it is left hepatic artery and left hepatic, and the J, right hepatic.
Okay, all right, we see you. So it is the easy way to ask you about branch of big artery. Of course, this is angio. He gave you this picture. So it is common to have this angio for both abdomen and neck. Okay, so
هو الاي جاسترودينال.
ما انا جاي لك اهو. هو A of course is aorta, and this is the same slides. B is the right common, C is the left common, D is the left renal, correct. E is renal also, right renal. F, corrugated or irregular, is a splenic artery. G is a hepatic artery or common hepatic, and the hepatic artery have like H. Where is H? No, G. H is superior mesenteric, and hepatic artery have a branch which is gastroduodenal artery from hepatic, and have right hepatic, left hepatic. What else? For where is L? L is inferior mesenteric. Anyone is wrong or missed? I think this is all. So just the branches of the aorta is very important. Of course, it is important to use the 4 picture like this, because we don't ask you in theory, we just give you a picture. Even in the brain, we have a picture in the brain, like circle of Wells and all this. So you need to use the 4. This is angio. So you need to know the angio of the perianeurysm, angio of branches of aorta, angio of the vessels or arteries in the lower limb is easy, and carotid and the branch of the carotid. Okay. All right. Of course, this is what we will do. It is EVAR or stenting of aorta, and usually stenting is below the renal, because if the above the renal, you need to be some sort of bypass to save the kidney. So it is important to know that nowadays in the aortic aneurysm, we just put a stent through the femoral artery. It is important to know this picture is anastomosis. Why we bring this picture besides the aortic aneurysm? Anyone have an idea? Why we put the intestinal blood supply or arterial supply besides the aortic aneurysm surgery? Because we tell the patient after aortic stent, we close one of the artery. Which artery we close? If you put a stent below renal, you close one artery. Which artery? Yes.
Superior mesenteric.
Inferior mesenteric. So we close inferior mesenteric. Yes, we close inferior mesenteric, and the patient have some ischemia, but is not gangrene. Why? Because of
Anastomosis.
mainly between
laterals.
with yes, with the branches of superior mesenteric, especially in the arched area, mainly from the branches of the middle colic and other or branches here. So although the patient after aortic EVAR or aortic stenting, he have severe abdominal pain due to little ischemia in the colon, but after a few days is improved because of the collaterals come out and the patient have no gangrene and no perforation. So this is very important and one of the common complication, and it is difficult to solve this problem because we put it so we don't have a branch or holes for inferior mesenteric, so it is closed. So again, so we close, so this area becomes ischemic. Of course, this is a portal vein. The main blood supply of the liver is come from portal vein, and the portal vein of splenic, superior, and inferior mesenteric veins come to form portal vein. Portal vein gives a blood supply of 80% of the liver is through the portal vein. This Whipple operation. Whipple operation is done for cancer head of pancreas. So we remove the gallbladder, common bile duct, we remove the duodenum, we remove part of pancreas, and we make triple anastomosis. So we make duodenum or jejunum to the rest of pancreas. We make for the common bile duct with jejunum, and duodenum or stomach with jejunum, we remove the duodenum. So this is a classic Whipple operation done for cancer head of pancreas or pre-ampullary tumor. Okay, of course, we back to the exam questions. So in the exam also, we bring this picture. Okay, of course, this is a liver. Sometimes it's difficult. If you compare to the color one is like this. So you have gallbladder, you have porta hepatis, you have inferior vena cava, and you have right lobe and left lobe. Of course, the gallbladder is related to quadrate lobe. Many of the people forget that, and the right border of quadrate lobe. So this is a picture of the liver and per area of the liver. I think we have something like this with color, but you can just imagine that. Okay, so this is what you have in exam, not this picture. This is laparoscopic picture. We ask you again, Dr. Abdurrahman, in cholecystectomy, we ligate cystic artery. What is cystic artery arise from? Anyone? You hear me?
Common hepatic.
Common hepatic.
Common hepatic. Common hepatic or right hepatic?
Right hepatic artery.
Right hepatic artery. Okay, and the right hepatic artery is from hepatic artery from the celiac tract. Okay, so what is the boundaries of calot or calotroph? Anyone? This is the calotroph. I make it bigger. So you can find the calotroph is lower is the cystic artery, cystic duct, which is become adherent to the common hepatic to become common bile. They have the lower border of the liver and contain the cystic artery again is branch of the right hepatic artery. Okay, so of course it's not bigger like this. So you can see in the laparoscope it's little like this, but it is just anatomy demonstration of the calot or calotroph. It's very important to know the boundaries. Simple because this is common operation in surgery. Of course, in England, the common operation is a gallbladder, colonic surgery, Weber operation. So it is important topic in Excel. The same picture again. This is also the same just to show the anatomy. After that, we have appendix, is a common operations. Is anyone tell me what is the blood supply of appendix?
Ventricular artery.
Arise from what? Appendicular artery arise from?
Ileocolic.
Ileocolic arise from?
Superior mesenteric.
Okay, so superior mesenteric give ileocolic give appendicular artery, and this is ileum, and this is appendix. What is the common site of appendix? 70% of appendix is what is common site? Retrocecal. Although the many surgeons say it is difficult appendix is retrocecal, but actually retrocecal is 70% of appendix is retrocecal. We have hepatic, pre-hepatic, or pre-ileal, post-ileal. We have pelvic. In the pelvic appendix, the patient can present it by what? What is other presentation in pelvic? Not diarrhea. No, diarrhea and pre-renal, renal. Pelvic appendix can present it by hematuria. So dysuria or hematuria. So in the pre-renal, renal can have diarrhea, but in the pelvic, he can have urinary problem like dysuria or hematuria. Okay, so appendix. Now we have a theory about appendix is important in immunity, and they have something speak about the immunity of the body is controlled by appendix, but we don't ask this in exam. Blood supply of the rectum is very important. Okay, so just anyone or Dr. Abdurrahman is still, what is the blood supply of the rectum? We have 3 arteries. If you ask you an exam, blood supply of the rectum, you tell me superior, middle, inferior, and which one is arise from where? Superior rectal is arise from what?
Superior rectal arises from inferior mesenteric artery.
It is a terminal branch of inferior mesenteric artery. What about middle rectal? Arise from?
Internal iliac.
Inferior arise from?
من البودندر internal pudendal
artery.
Just internal pudendal
branch.
posterior.
Okay, so we have 3 artery: superior rectal, middle rectal, and inferior rectal. Okay, so it's very, very important. Okay, so in the rectum, what is the level between ectoderm and endoderm? What we call it?
Dentate line.
Dentate line. So above that it is endo, below that is ectoderm. So if you have hemorrhoid and you did it without anesthesia, so it is above dentate line, you can do rubber ligation above. Below it, you must have anesthesia. So it's very important. Okay. I just remember you, this is fossa, is ischoanal, not ischorectal, but it's the old book is called still ischorectal fossa. After that, we can have a picture of the ERCP. Of course, you know ERCP, and what is this structure? Is the common bile duct, and this is the gallbladder but calcified. Okay. Sometimes they will give you picture of the CT, so the CT is normal. Liver, of course, they don't write the names. Stomach, pancreas, some veins, inferior vena cava. It is important to know aorta. In most of all the people, they have calcification. This is above the aorta is the crus, not a branch of aorta. Or this area is a crus of the diaphragm. And of course, this kidney and spleen. So you can find something like this. Or like this in the scarf. Okay, so back to the exam. So the exam is, this is a pelvis. We're about to finish, but I make it bigger. Okay, so apart from Dr. Abdurrahman, anyone ready to answer? Okay, anyone who need to answer? Don't be shy, anyone?
Okay, Dr. I'm with you.
Okay, Dr. Muhammad. Okay, I make it bigger. Just tell me, start it from A. You see the picture. Of course, it is the lateral view or sagittal section of the pelvis of the female patient. Okay, so
Okay.
started by A.
A is symphysis pubis.
Yes, correct.
B is the urinary bladder.
Yes.
C is the uterus.
Yes.
D is the rectum.
D, E, B, C, D. Yes, rectum. Yes. Okay. All right.
E is the urethra.
Urethra. Okay.
F is the vagina.
Yes.
E, F, G. Where is G?
Hmm?
Oh, okay. G is the cervix. Cervix of the uterus.
Say again. G.
Cervix.
G. G is this one or G? This one, G. Yes, cervix.
No,
uterus,
no.
Yes. Yes, yes. G.
G.
Okay. After that.
H is Douglas pouch.
H is Douglas pouch. Yes. Okay.
I is the anal canal.
Okay.
J is the sigmoid colon.
Yes.
J.
KL.
K is the fifth lumbar vertebrae. L5.
Yes. L5
Okay.
and L is
L is first S1.
M.
N is M.
No,
oh,
M.
okay, okay.
M.
M is what is the spinal cord, or the
It is lower, so lower.
yeah.
Okay, we see it, no problem.
Phylum terminal.
Yes.
Yeah,
All right.
okay.
So again, you are correct. A is the symphysis pubis, B is the urinary bladder, C is the uterus, D is the rectum, E is the urethra, female urethra, of course. F is vagina, G is the cervix of uterus, H is the Douglas pouch or recto-uterine pouch or Douglas. I is inner canal. J here is the sigmoid colon S shape. K is L5. L is S1. And the end of spinal cord is coda equina or coda terminalis. Okay. So it's easy, but it is just, if you see the picture, just enumerate. It started, of course, A, B, C, D, E, F, and usually have a mark and he mark you. So it is easy station. Usually anatomy is all or none. So this is the male patient, of course, just to know the anatomy. Of course, urinary bladder first, rectum, but in female, if you see before, you can find the urinary bladder followed by uterus in between urinary bladder and rectum. Okay. If you see this picture, the same doctor, what does this arrow indicate?
What is this is a prolapsed disc between L4 and L5.
Okay, of course, we don't put a number, I just put for demonstration, so L4. Yeah. How to know it is L4 and 5? Because if you come down, this is S1.
Okay.
So L5, L4. So it's easy to come from down. Okay?
Okay.
All right. So for the abdomen, that's it for the abdomen. So for the abdomen, or for the anatomy, again, we have 3 stations. And as you see, they give you a picture and just enumerate. And usually he can ask you something like abdominal aortic aneurysm, blood supply, what is the origin, cannot react. Of course, put in your mind, the common operation done is appendectomy, cholecystectomy, colectomy, abdominal aortic aneurysm. We don't ask you more detail in others. So it is just spotting. In the past, with the cadaver, we use plastinated. Nowadays, because the exam all over the world, so we use this picture. So I sent it to you. Get through the anatomy today. So get through the anatomy, or if you Google Macmillan Atlas of Human Anatomy, you can find this picture. This picture all is no color, and you just have a number, and you just write what is this number. So it is important to use this picture because this is picture for many students is not familiar because no color is clear, but because we use the four looking atlas in color way, but this is our diagrams, but this is cadaveric or plastinated nowadays, so it will be the same. Okay, so this is as regard the anatomy. Next time we will discuss thorax and head and neck, and maybe if we have a time we discuss the lower limb. Okay. So anatomy station, 3 stations.